Assalamu alaikum. Okay, we are going to discuss an important subject in hematopathology, which is lymphoid neoplasm, which include both non-Hodgkin's lymphomas and Hodgkin lymphomas. Before starting to discuss each tumor and neoplasm, lymphoid neoplasm separately, several general concepts should be considered, okay, before getting deep discussion into each individual tumors. One of these general concepts, including that there is variable clinical presentation and behavior. So there's wide variation between clinical presentation and behavior for each tumor, lymphoid tumor or lymphoid neoplasm. And actually, ultimately, this leads to different management and treatment. What's mean by leukemias? Leukemias mean that the lymphoid malignant lymphoid cells involve bone marrow and peripheral blood. Okay, this is mean by leukemia, which means involvement of the bone marrow and peripheral blood by malignant lymphoid cells. While lymphoma means there's mass or tumor that usually affecting lymph nodes or other tissue, what's called extranodal involvement. Again, another point should be considered that these lymphoid neoplasm have a great potential to involve various tissue as well as lymph nodes, and can reach liver, spleen, bone marrow, and peripheral blood. Thus, it is a systemic disease rather than local neoplastic process. Therefore, this point is very important, okay, in consideration and in making the diagnosis of lymphoma, and should always differentiate lymphoma from other neoplasm, because lymphoma usually a systemic disease, mean there is already secondary metastasis, and thus every lymphoid tissue first line of treatment after the diagnosis will be systemic chemotherapy. This is a very important point, should be considered. Okay. There is an overlapping, okay, between the clinical presentation and, okay, behavior of these lymphoid neoplasm. Thus, this neoplasm should be classified or distinguished or making sure diagnosis by certain characteristic morphological features, as well as actually we classify lymphomas in general into Hodgkin lymphomas and non-Hodgkin lymphomas. Hodgkin lymphomas, the characteristic things is the presence of what is called RS cell, Reed-Steinberg cell, giant cell, which will be discussed thoroughly later. And these are usually scattered and overnumbered by reactive inflammatory cell that surrounding these scattered RS giant cell. Again, the biological behavior and the clinical treatment of Hodgkin lymphoma are also different from those that making the distinction practical. B and T cell tumor, then the non-Hodgkin lymphoma, either of classified into B or T, according to we have B lymphocyte and T lymphocytes. This classification, okay, depend on the journey of B and T cell, journey of maturation, either within bone marrow or within thymus gland or lymph node. And accordingly, the diagnosis and classification will rely on certain expression of certain antigens, okay, that are characteristics for B or T or other types of lymphocytes, natural killer cell. Also, sometimes that reactive process is quite similar to the neoplastic process. So how can we differentiate? Differentiate by using certain tests that can differentiate antigen receptor genes or protein products by used to differentiate whether this a clonal neoplasm. Mean clonal, mean that the characteristic structure of this protein produced are clonal, means produced by single cell, okay, means single cell have got a mutation and producing the same antigen or protein. This is an important aspect, okay, in the differentiation between reactive and process. Look for this diagram. We have here bone marrow, which is mean, in the bone marrow, B cell will be differentiated. These are precursor B cell, and in the precursor B cell, we have counterpart lymphoma, which is lymphoblastic lymphoma or leukemia, or what is called ALL, acute lymphoblastic leukemia or lymphoblastic lymphoma. And these are naive B cell, and the naive B cell, okay, if neoplastic process happened in this cell, it will give us small lymphocytic lymphoma, which is parallel to the chronic lymphocytic leukemia whenever these malignant neoplastic cell seen in the peripheral blood or in the bone marrow. Again, this naive B cell, it will enter the lymph node, okay, and it will reside in the mantle zone. And if this cell, okay, malignant lymphoid cell have the characteristic of mantle cell lymphocytes, it will produce what is called mantle cell lymphoma, and it have the same characteristic, antigenic characteristic for mantle cell, normal, genuine mantle cell, okay? Again, after maturation, it will, after antigenic exposure, it will getting into the germinal center, okay? And in the germinal center, we have many types of lymphoma, either follicular lymphoma, Burkitt's lymphoma, diffuse large B-cell lymphoma, and even the Hodgkin lymphoma. After germinal center, we have what is called marginal zone, and from marginal zone, we will get either marginal zone lymphoma, diffuse large B-cell, and small lymphocytic lymphoma. Some of the B-cell, it will differentiate it to antibody secreting cell, which is called a plasma cell, and neoplastic process that affecting the plasma cell called multiple myeloma. This is a good diagram, showed that that the lymphoma classified according to the steps of maturation of this cell. Again, the same thing can be applied for T lymphocytes. We have here double negative lymphocyte double negative means CD4 negative, CD8 negative, which is differentiate to double positive, okay? And then it will differentiate to CD4 positive or CD8 positive, helper or cytotoxic. And if malignant process affecting the lymphocyte at this stage, the presentation will be as lymphoblastic lymphoma leukemia. While after maturation, we have what is called peripheral T cell, which is usually found in the paracortical area. Okay, and these usually a neoplastic counterpart of peripheral T cell, it will give us peripheral T cell lymphoma. Another important difference between non-Hodgkin lymphoma and Hodgkin lymphoma that although non-Hodgkin lymphoma could be its manifestation at a particular sites, but there is usually wide dissemination at the time of the diagnosis. Therefore, only systemic chemotherapy is usually curative, while Hodgkin lymphoma usually arise at a single site, and it's spread usually in a predictable way or predictable fashion. Okay, mean that one lymph node it will be involved. Second one, which is near or adjacent to first one, will be involved. Therefore, sometimes considered as a local process. Okay, have this just in the early stage. Okay. Accordingly, an important classification of wide range of new lymphoid neoplasm, WHO had its own classification, okay, which depend on the morphology, cell of origin, usually determined by immunophenotyping, and clinical feature and genotype, mean certain molecular or cytogenetics abbreviations. This is the base that depend on the WHO classification arranged, okay, according to these bases. Okay, in general, it includes tumors of the B cell, tumor of the T cell and natural killer cell, and number 3, Hodgkin lymphoma, which is a little separated. These including the non-Hodgkin lymphoma, and this is a summary for the classification, WHO classification of lymphoid neoplasm. Last classification, I think in 2016, okay, I think more than 80 types of lymphoma presented in that classification. Okay, in this classification, we have precursor B cell, BALL, and the peripheral or mature B cell neoplasm, which include small lymphocytic lymphoma, mantle cell lymphoma, this is an important, follicular lymphoma, we have extranodal marginal zone lymphoma, and diffuse large B cell lymphoma and Burkitt lymphoma. This is the most important B cell lymphoma. Okay. Again, in T cell, we have a precursor T cell lymphoma, which is lymphoblastic lymphoma, TALL. And in the peripheral or mature one, we have peripheral T cell lymphoma. We have what is called a types of lymphoma that affecting the skin called mycosis fungoides. We have another type which is called anaplastic large cell lymphoma, and many other enteropathy type T cell lymphoma, panniculitis, and so on. In Hodgkin lymphoma, there is an important classification, and it will be discussed. Okay. This is a table summarize what we will discuss in more details in the next few slides. Okay, we have precursor lymphoblastic ALL and precursor T cell. We have small lymphocytic lymphoma, we have follicular mantle cell lymphoma, and there is some immunophenotyping characteristic translocations for each one, which should be okay. So our discussion will be focused on these types of lymphoma, except multiple myeloma, which is usually excluded from our lectures, and I think one of our colleagues will give you a lecture discussing these. Starting with the chronic lymphocytic leukemia or small lymphocytic lymphoma. Small lymphocytic lymphoma mean that the lymphoid neoplasm is just presented as lymphadenopathy, without involvement of the peripheral blood or bone marrow. In case of involvement, or there is certain cutoff increment in the lymphocytes, it will be converted to leukemia. So the difference is in the extent of the peripheral blood involvement. So if we have lymphocyte count more than 1,000 cells per microliter, the patient is diagnosed with CLL. So the number 4,000 is very, very important cutoff that separate leukemia patient from that of just lymphocytic lymphoma. Usually the pathogenesis of this tumor, this is tumor very slow growing, tumor, and we have many cases, diagnosed accidentally by examination or by radiological process for another complaint or problem, and discovered these types of lymphoma. The pathogenesis, they are slow growing tumor, suggesting that the tumor cell survival is more important than tumor cell proliferation. So tumor contain high level of BCL2. BCL2 as an important, BCL2 is an important gene that regulates apoptosis. So if this gene dysregulated, so there will be more survival for this cell. So the problem is survival or prolongation of the life of the lymphocyte rather than proliferation of these lymphocytes. Again, we have immune dysregulation, which means these lymphocyte, it will secrete certain immunoglobulins, and there will be certain immune dysregulation associated with the pathogenesis. Usually by morphology, microscopically, speaking microscope, what we see by microscope, usually lymph node is totally effaced, and I will discuss what we mean by effacement in a practical session. So there will be effaced، يعني انمحاء، يعني ممحية تقريبا ال characteristic feature of the lymph node. So there's effacement by diffuse proliferation. We have diffuse a process of proliferation. It is not a follicular process of proliferation. It is a diffuse process of a small lymphoid cell, and this cell is just similar to the mature lymphocytes. It is a small lymphoid cell similar to the mature lymphocytes. Actually, there is just few foci of mitotically active cell, which is called proliferation centers. And these proliferation centers is composed of prolymphocytes, and it is very characteristic feature for small lymphocytic lymphoma. Okay, and sometimes, many times, it is very helpful, okay, to request CBC, okay, and blood film for those patients, and many times we will found that there is absolute lymphocytosis and a characteristic smudge cell. If you have an idea, I think you have an idea about this smudge cells, okay, during discussion of the leukemia. So this is lymph nodes, and you see, if you compare this lymph node with what we will see in normal lymph node or just reactive lymph node, there is effacement, total effacement of the architecture. There is no cortex, no medulla, and this effacement, by as you see, it is a diffuse process. Diffuse process mean this process, it's not forming follicles, not forming a follicles. It's just a diffuse process. Okay. And this is a hyper view for small lymphocytic lymphoma, and you see that mainly we have small lymphocytes, okay, and this is a little bit larger than these small lymphocytes. This is larger cell, okay, and surrounded by other small mature looking. It is not mature cell, it is not normal cell, but it look like normal lymphocytes. So it is smaller size, and surrounding these rather than larger one, which is called the prolymphocytes, that have a large nucleolus, okay, and this is called proliferation center, which is very characteristic for. What are the main immunophenotyping for this cell? As you know, this is a B cell tumor, so we will expect it will express B cell marker, including CD19, CD20, and again it will express CD23, which is also expressed in some what is called dendritic cell, which is found in the germinal center. But look at this discrepancy or controversial fact. Although it is B cell, but it is apparently express CD5, which is a T cell marker. And in case we had expression of CD20, CD5, CD23, okay, it is usually this feature, it will goes with CD5. Oh, it will goes with small lymphocytic lymphoma, okay, because CD5 usually just expressed in T cell and expressed in the neoplastic lymphoma, like small lymphocytic lymphoma and mantle cell lymphoma. Okay, clinical feature, usually they are rather old age, 60 and above, okay, and they give a long history of either generalized lymphadenopathy. Sometimes they are presented with hepatosplenomegaly and other long-standing feature without toxic presentation, like many other aggressive types of lymphoma. And usually the prognosis and the course is extremely variable, and many patients live more than 10 years after diagnosis and die of a related cause. But the mean survival or median survival is, we're talking about 4 to 6 years. and they have tendency to transfer to a more aggressive tumor, either pro-lymphocytic lymphoma or diffuse large B-cell lymphoma. Another type of lymphoma, which is follicular lymphoma. Follicular lymphoma, it is a relatively very common type of non-Hodgkin lymphoma, accounting about 40% of adult non-Hodgkin lymphoma in the United States. But this figure is very quite different from the figures that we have in Iraq. It is considered a relatively rare types of lymphoma that's seen in our country. Okay, what are the pathogenesis of this type of lymphoma? Again, BCL2 expression or overexpression. BCL2 it is not a germinal center marker, but there is translocation in chromosome 14, 18. Translocation of BCL2 gene, which is found on chromosome 18, to the IGH locus in the chromosome 14, and this translocation, okay, induce these gene to express more BCL2 protein, which is responsible for prolongation of morphology. Again, there is effacement of the lymph nodes architecture, but here the effacement is by a nodular proliferation rather than diffuse proliferation. So the predominant neoplastic cell is larger, slightly larger than the resting lymphocytes. So, and these have angular cleaved nuclei. We have cleaved nuclei, and it is called centrocytes. It is essentially similar to the centrocytes that's seen in the normal germinal centers. Okay, and these cleaved cells usually mixed with a variable numbers of more larger cell with vesicular chromatin and multiple nucleoli. This is called centroblast. Okay. Immunophenotyping feature, usually it is again a B-cell lymphoma and should express CD19 and CD20. Besides that, they usually express CD10 and BCL6, and both CD10 and BCL6 are germinal center marker, which is usually expressed in germinal center cells. And most importantly, expression of BCL2, and this is very important in differentiation between this type of lymphoma from follicular hyperplasia, which is just reactive condition, because it is sometimes hard to differentiate by morphology between follicular lymphoma and follicular hyperplasia. So usage of this marker BCL2 is very helpful in making the differentiation. Look, in follicular lymphoma may progress to large B-cell lymphoma, diffuse large B-cell lymphoma, and this is one feature. Look to this gross lymph node. From a gross examination, you see it is about 3 cm large lymph node, and gross examination we have nodular nodular cut section, and these are two pictures. In the left for reactive lymph node. Okay, this is for reactive lymph node, and this is for lymph node involved by follicular lymphoma. So look there is still, we have architecture, we have cortex, we have the medulla, and we have size, variable size of lymphoid follicles, but these lymphoid follicles usually still present just within the cortex, while in this lymph node, which is involved by follicular lymphoma, if you see that we have many follicles or nodules, and these nodules involve the whole architecture of the lymph node. Okay, this is what is called effacement. Thus, even the medulla is involved by these follicles, and usually the follicles, it is rather monomorphic in size. Yes, which is just similar in size, while there's much more variability could be observed in the lymph node that affected by reactive follicle. This is a more high power view, and if you see that this is a germinal center and this is a mantle zone that's surrounding the germinal center, and the border between these two zones, it is very distinct border. Okay, and it is usually goes with a reactive process, while in this picture, if you see, we have a rather larger lymphoid cell. If we have more a close or more high power view, we can observe the cleaved nuclei, and also there is obliteration for the border between mantle zone and germinal center, and this feature and this morphology goes more with the follicle. Again, we have to see, we have in here, we have polymorphic, more heterogeneity in the left side, in the A, while it is here, it is more homogeneous, which is actually goes with the neoplastic process, because there is a clonal expansion of these neoplastic lymphoid cell. Again, this high power view showed the difference between a small lymphocytic here, a small lymphocytic lymphoma, small cell, okay, with prominent nucleoli, okay, or clumping of chromatin of the cells, while here we have rather larger cell with the cleaved nuclei, which is it is called centrocyte. It looks like centrocytes, larger cell with irregular nuclear membrane and a cleaved nuclei, which is very characteristic for follicle. Another type of mature B-cell non-Hodgkin lymphoma is mantle cell lymphoma, which is composed of cell resembling naive B-cell that found in the mantle zone. So this lymphoma is corresponding to the cell that found in the mantle zone, normal mantle zone found in the normal lymph node. It just accounts 4% of non-Hodgkin lymphoma. Morphologically, in mantle cell lymphoma, the lymph node again will be completely effaced, and effaced by proliferation, lymphoid proliferation either will be diffuse or vaguely nodular. Vaguely means something, it looks like nodules, okay, not well defined, okay, clear cut nodules, but there is an aggregation. It looks like nodules. The tumor here is slightly larger than normal lymphocytes, okay? And the nucleus will be irregular, and inconspicuous nucleoli means nucleoli cannot be seen easily, inconspicuous, with scanty cytoplasm. Immunophenotyping and genetic feature. This is an important cytogenetics feature for mantle cell lymphoma, which is translocation 11-14, by which cyclin D1 gene translocated into IGH locus in 14 chromosome. So there will be expression of cyclin D1, which is very, very characteristic and diagnostic feature for mantle cell lymphoma. Again, these types of lymphoma, beside expression of pan B-cell antigen like CD20, CD19, it will express CD5 like small lymphocytic lymphoma. But cyclin D1 is very helpful diagnosis, okay, that confirm. Another type is diffuse large B-cell lymphoma. This is the most common type of non-Hodgkin lymphoma seen in our country, and it affects 50% of adult non-Hodgkin lymphoma in worldwide, okay? And it have usually an aggressive natural history. Here, the morphology, the neoplastic cell, from its name, it is called, it will be not small or medium size, it is large lymphoid cell. And these cells about 3 to 4 times larger than resting lymphocytes. Again, the cell will be round or oval. There is modest amount of pale cytoplasm. Again, chromatin will be dispersed, and usually it is very important there is several distinct nuclei. It has, usually this type have prominent nucleoli. And sometimes these tumor cells are highly anaplastic, okay, and include very large tumor cell, okay. Anaplastic cell mean cell with complete indifferentiation, mean without any differentiation. Anaplastic cell, anaplasia, which is mean indifferentiation. And sometimes these giant cells, it look like are a cell that's seen usually in Hodgkin. So this figure showed that we have relatively, or it is very actually, it is large lymphoid cell, okay, with relatively abundant eosinophilic cytoplasm, and the nuclei have vesicular chromatin pattern with prominent nucleolus. Look for this, for this nucleolus, for this nucleolus, for this, okay. And there is many mitotic activity. This one, this one, this one, this all high. All these are of prominent mitotic activity, and this type previously named anaplastic type because, or immunoblastic type, because actually they tend to classify non-Hodgkin lymphoma, diffuse large B-cell lymphoma, into 3 types: centroblastic, which is equal or equivalent to the centroblast, and immunoblastic type, which is this type, which is equivalent to the immunoblast, and there is what is called anaplastic, which means with complete indifferentiation. What are the immunophenotyping features? Because diffuse large B-cell lymphoma, look for this point. Diffuse large B lymphoma, it looked like the end stage of many types of tumor. Many lymphoma will converted, okay, it converted to an aggressive type of lymphoma, and these aggressive type of lymphoma to look it become resembling or become actually diffuse large B-cell lymphoma. So many lymphoma started with indolent type. If there is no treatment or for another cause or for a cause or another, it will convert it suddenly for diffuse large B-cell lymphoma. One of the best example, follicular lymphoma. Many types of follicular lymphoma, okay, will terminate into diffuse large B-cell lymphoma. Small lymphocytic lymphoma can be transformed to diffuse large B-cell lymphoma. So, immunophenotyping of this type, it is B cell, CD19 positive, CD20 positive, sometimes CD10 positive, BCL2, which are markers for follicular lymphoma. And this is give an idea about for us that this is the background lymphoma before, okay, before transformation to the diffuse large. The clinical feature about usually this type of lymphoma affecting old age, 60 years and old, and just about 15% of childhood lymphoma, and the patient presented with rapidly enlarged and symptomatic mass, and what is called extranodal presentation means that we have lymphoid neoplasm outside the lymph nodes. This is called extranodal presentation. Another important feature, okay, this type of lymphoma usually does not commonly involve liver, spleen, and bone marrow. Despite that this type of lymphoma is aggressive type, rapidly growing, but it does not involve liver, spleen, and bone marrow. Okay, in contrast to the indolent, other types of indolent lymphoma like follicular lymphoma or small lymphocytic lymphoma, it is much more commonly involved liver, spleen, and bone marrow. And usually without a treatment, this is an aggressive tumor and it may cause death. And complete remission could be achieved in about 60 to 80% of patients. Okay, let us discuss another type of Burkitt's lymphoma, which is again a B-cell lymphoma. This type of lymphoma usually either found in certain endemic area in Africa, or it may presented sporadically in other geographical area, including United States, Middle East, okay? This is what is called sporadic case. Actually, in both endemic in Africa and non-endemic, the disease are identical, and although there is some clinical and virological. What are the pathogenesis of this Burkitt lymphoma? Like other type of lymphoma that are previously discussed, you see that many type of lymphoma is associated with certain cytogenetics feature. So here we have again there is a translocation that involved MYC gene, which is an oncogene, MYC gene, an oncogene responsible for proliferation. And this MYC gene, which is found in 80 chromosome, either most commonly, okay, translocated at the same site of follicular and mantle IGH gene at chromosome 14, okay, and then it will be activated and start to give, okay, frequent, okay, non-stop signals for proliferation, or sometimes it will translocate into another chromosome, like chromosome 2 or chromosome 22, okay. And in most cases, they say that in most cases, endemic cases, and about 20% of sporadic cases, there is an what is called latently infected. The tumor cell is latently infected with Epstein-Barr virus. So there is a strong association between Epstein-Barr virus and these types of lymphoma, Burkitt's lymphoma. Here, the morphology, okay, if we jumping to another slide, okay, to discuss morphology, the cell will be of intermediate size, okay, it is round or oval lymphoid cell. Sometimes there is prominent nucleoli. The most important characteristic feature is that there is high mitotic figure, and there is many apoptosis, which is can be identified by presence of tangible body macrophage. These macrophage will engulf the apoptotic bodies, and if you see that this give the presence of dense proliferation, okay, that alternate with this, okay, lighter area, it gives what is called starry sky appearance. Starry sky meaning السماء المنجمة, السماء ذات النجوم. Okay, this is another feature, another slides, okay, show that there is brisk mitotic activity. This mitosis, this another mitosis, and these that intermediate types of lymphoid cell with prominent nucleoli. Clinical feature, usually this type of lymphoma affecting children and young adults, both in endemic and non-endemic area. Usually in endemic area, mainly it will involve maxillary or mandibular masses, whereas abdominal tumor, it is much more common in non-endemic type. So presented with abdominal tumor that affecting either the bowel, retroperitoneum, and ovaries. And actually, I have seen many cases that are diagnosed as Burkitt lymphoma and presented with abdominal or ovarian masses in our country. It is considered one of the fastest growing human neoplasm. So mean that the growing of the tumor is very fast, okay, and deterioration may occur within a matter of days. Therefore, sometimes clinician, okay, try to take from us actually the result as soon as possible, okay, to start the treatment. I will talk about plasma cell neoplasm and related entities. Usually plasma cell, it is a mature B cell and have the ability to secrete immunoglobulins. So neoplastic plasma cell is somewhat different from other lymphoid cells that were discussed previously. So these neoplastic cells usually virtually secrete monoclonal immunoglobulin or part of immunoglobulin. And these immunoglobulin could be serve as a tumor marker and usually have a pathological consequence, as we will discuss this in a few slides later. If we identify this immunoglobulin, which is monoclonal immunoglobulin, by blood during electrophoresis, it is called M protein. M coming from myeloma, which is a neoplastic lesion of a plasma cell, myeloma. And now, neoplastic plasma cell either synthesized an excess amount of immunoglobulin light chain along with complete immunoglobulins, and you know that immunoglobulins have heavy chain and light chain. Sometimes these neoplastic cells secrete complete immunoglobulin or just the light chain. The light chain can be secreted in the urine, therefore it can be detected in the urine. So a patient are suspected to have, for example, multiple myeloma or plasma cell neoplasm. Sometimes they request for a urine test for a light chain, which is called Benz-Johnson protein. These abnormal proteins are associated with several clinical pathological entities. Now, multiple myeloma, which is one of the most common lymphoid malignancies. Usually multiple myeloma, it's fairly common types of malignancy, affecting old age. The median age is about 70 years, and it is much more common in males, especially those of African origin, talking about USA. It principally involves bone marrow and usually associated with multiple lytic lesions throughout the skeletal system. So, diagnosis is usually made by finding the M protein, which is produced by neoplastic plasma cell or what is called myeloma cell, and about 60% of those M protein are of IgG type, followed by IgA type. Sometimes a special case plasma cell produce just light chain, kappa or lambda chain, and usually these called Benz-Johnson protein and can be excreted in the urine and can be quantitatively detected in the urine. What are the morphological changes in multiple myeloma? Usually multiple myeloma, it is a multifocal destructive skeletal lesion. So we have multiple lytic lesion affecting vertebral column, ribs, skull. Okay, sometimes we have seen many cases with usual story or scenario or history of disease presented with multiple lytic lesion in the vertebral column in old male. First, we have two differential diagnoses: either metastatic prostatic cancer, or secondly, which is more common with lytic lesion, is multiple myeloma. So sometimes these bone destruction lead to pathological fractures, and usually the appearance radiologically as a punched out defect of 1 to 4 cm in diameter. The microscopical examination of the bone marrow usually show increased number of plasma cells, which you should increase should be greater than 30% of all cellularity. So to make the diagnosis of multiple myeloma, we have, beside multiple lytic lesion, we have bone marrow examination show infiltration of the bone marrow by neoplastic plasma cell by more than 30% of whole cellularity. Myeloma cell or neoplastic plasma cell, it is just resemble to the normal plasma cell. You know that the plasma cell is a lymphoid cell with eccentric nuclei and usually the chromatin pattern called what is called cartwheel appearance. يعني مثل العجلة مال العجلات اللي هي يعني تاير شي كارتويل اللي هي مال العربات القديمة الخشبية أو مثل وجه الساعة اسمه الكارتويل appearance, but usually with a prominent nucleoli. هذا هو the difference between الميلوما cell and normal plasma cell, and usually containing cytoplasmic inclusions represented immunoglobulins. Beside multiple lytic lesion and bone marrow involvement and sometimes serological findings of M protein or Benz protein, we have it's usually associated with renal involvement and myeloma nephrosis. It's called myeloma nephrosis due to deposition of a proteinaceous cast representing the Benz protein that could obstruct the distal convoluted tubules and collecting tubules, and sometimes presented with renal failure. So look for this picture. Usually the skull is affected by multiple lytic lesion, or what is called punched out lesion, usually of 1 to 4 cm, affecting the skull. And this is a bone marrow aspirate, shows these neoplastic plasma cell, or what is called myeloma cell. Look for the eccentric nuclei and abundant nucleoli, and these are what is called the inclusions, which containing the immunoglobulin. So if we found that the cellularity of the bone marrow or that this myeloma cell represented more than 30% of the whole cellularity, so it is sufficient for the diagnosis of multiple myeloma. Clinically, we say that sometimes the presentation either as some bone pain, or sometimes presentation with pathological fracture. Many cases presented with old age, were presented with pathological fractures. Okay, and workup of such case sometimes revealed multiple myeloma. Again, due to multiple lytic lesions, so this patient usually have hypercalcemia, and these hypercalcemia sometimes have neurological consequences. Again, decreased production of immunoglobulin, because the neoplastic cell, it will switch for production a special type of immunoglobulin, monoclonal immunoglobulin. So the number of other immunoglobulins will be decreased. So these patients are susceptible for recurrent bacterial infection. Again, we have 50% of patients have a risk for renal failure because of the proteinaceous deposition of light chains within the collecting tubules and convoluted tubules and collecting ducts. Also, laboratory analysis usually showed M protein in the blood, or light chain Bence-Jones protein in the urine. And usually the diagnosis will rely on radiological, beside laboratory findings, and the confirmation usually done by bone marrow examination to get the definite diagnosis, especially in suspected in strongly suspected imaging studies. Usually, patient with multiple myeloma, if untreated, it will just survive for not more than 6 to 12 months, while those with much more indolent myeloma may be asymptomatic for many years, and the median survival rate is about 4 to 7 years. Okay. We'll discuss another types of lymphoma, which is called Hodgkin lymphoma. And as we mentioned previously, this type is characterized by presence of certain cell called Reed-Sternberg cell or RS cell, which is a giant tumor cell. And usually we have also said that usually it affects single lymph node, and the mode or fashion of separate of this tumor is usually into the contiguous nodes or in the adjacent nodes, means steps by steps, and not usually from the start. It is a systemic and could involve many lymph nodes regardless of the region of these lymph nodes. Okay, we have to take an idea about the classification of these types of Hodgkin lymphoma. Usually it's classified into main two types: classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. And the classical Hodgkin lymphoma have four important subtypes, which is nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte depletion or lymphocyte depleted Hodgkin lymphoma. Okay. All these classical Hodgkin lymphoma are characterized by presence of RS cell, which have certain morphological and immunophenotypical feature, while the lymphocyte predominant, nodular lymphocyte predominant Hodgkin lymphoma, usually it express B cell marker to this to the cell, which is called L. Okay, what are the morphology of Reed-Sternberg or RS cell? It is large cell or very large cell reaching the size 45 micrometer, and 45 micrometers means it is about 5 times larger than normal lymphocytes. Okay, and usually it has enormous multilobate nucleus, and they have very prominent red nucleoli, and usually have slightly eosinophilic cytoplasm. The most characteristic feature is what is called two mirror image nuclei or nuclear lobes, each containing large inclusion like acidophilic nucleolus surrounded by a clear zone, which is an important feature of what is called owl eye appearance. Owl eye appearance. Okay. The immunophenotyping of these cell okay, of RSL is expression of CD15, CD30, but usually it does not express either CD45, which is leukocyte common antigen, which is usually expressed in all leukocyte, but it failed to express this type of CD, okay, for RSL. Again, it will not express neither B cell or T cell. And look, this is what is called RSL. So it is very, very large cell. Okay, it is very large cell. Its diameter reaching 45 micrometer. 45 micrometer, 5 times than the diameter of this adjacent lymphocytes, and it sometimes have many two or more nucleoli, and these nucleoli nuclei have two or multi-lobed nuclei, okay, and it has very prominent red nucleolus that surrounding by a clear halo, and it will give an appearance of owl eye appearance, يعني عين البومة, which is very characteristic feature and helpful in making the diagnosis of this. So we will discuss the first type of classical Hodgkin lymphoma, which is mixed cellularity, and usually this is the most common type that affecting patients, okay, above 50 years old, and it accounts 25% of all cases of Hodgkin lymphoma, with male predominance. Usually in this type of lymphoma there is many classical RSL, okay, in the background of heterogeneous inflammatory infiltrate, okay, that containing small lymphocytes, most importantly eosinophil, plasma cell, and macrophage. And this is more common or more likely to be disseminated and to be associated with systemic manifestation, or what is called B cell symptoms, okay, and I think it will discussed by hematologists, okay, if you take this lecture in a clinical theme, okay, it will be discussed more, and you can discuss about what's called by B symptom, like weight loss, fever, and malaise, and what else. Okay, this is a section that shows, okay, effacement of lymph nodes, and we see that there is many scattered RSL or Hodgkin cell. This one, this is another one, this is another one, this is another one, okay, in the background of heterogeneous infiltrate, okay, containing plasma cell, neutrophil, and most importantly eosinophil. Okay, another type, what is called nodular sclerosis Hodgkin lymphoma. This is another type of classical Hodgkin lymphoma, which is actually the most common one seen in young adult, either women or men, and it will be very striking propensity to involve lower cervical, supraclavicular, and mediastinal lymph nodes. Most patients are adolescent or young adults, but the overall prognosis is usually excellent. Usually the common story is that presentation is either cervical lymph node or mediastinal lymph adenopathy in young female, 20 years old or plus minus 5 years. Okay, this is the classical history or story of this disease. This type of Hodgkin lymphoma characterized by a presence of lacunar cell, which is mean are a cell but surrounded by a space, okay, or what is called lacune. مثل شلون غرفة خلينا نقول. Okay, and again this RSL have multilobate nucleus, multiple small nucleoli, abundant pale staining cytoplasm. Okay, and the most important, another important feature beside the lacunar cell is the presence of fibrosis. Okay, there is dense fibrosis that usually transect the lymph node and making the lymph nodes as nodules. Okay, look for this type. So we have dense fibrosis. Okay, and this dense fibrosis band, large broad collagen bands that separate the lymphoid tissue into a nodule, and this is what is called lacunar cell. Mean there is a space, okay, that surrounds each Hodgkin cell, and this is, I think, this is a cellular phase of nodular sclerosis. Yeah, because there is an abundant, numerous amount of RS cell. Okay, again, the background of this RS cell, again, of reactive or heterogeneous type, including eosinophil. This type, this another type of Hodgkin lymphoma, which is nodular lymphocyte predominant Hodgkin lymphoma, which is not classical type. It just account 5% of cases, and it characterized by presence of certain variant of RS cell, which is called lymphohistiocytic cell and H cell, which characterized by presence of delicate multilobed nucleus that resembling popcorn, or what is called popcorn cell. It looked like popcorn. Okay, and these other reactive cell like eosinophil and plasma cell and what else, usually it is scant. Okay, if you see presence of eosinophil usually exclude the diagnosis of nodular lymphocyte predominant Hodgkin lymphoma. Usually the immunophenotyping, again, it is quite different in LH variants, okay, because it usually express B cell marker CD20 and fail to express CD15 and CD30, which are the main immunophenotyping marker, okay, for classical RS cell. Again, it usually either affecting cervical or axillary lymph nodes, and this is type of Hodgkin lymphoma usually has an excellent prognosis. Okay. So we will discuss a few notes about lymph node biopsy. First of all, a note that should be considered that we always prefer to take whole lymph node biopsy, which means all lymph node taken and excised and sent for histopathology rather than taking core biopsy. Another important that should be considered in a case of selection of lymph node, if we have generalized lymphadenopathy, usually inguinal lymph node should be avoided because many times it gives no specific finding, because there is usually associated, sometimes they have associated with chronic non-specific reactive lymphadenitis, or sometimes even fibrotic changes, and axillary and cervical lymph nodes usually more likely to be informative. Another point that should be considered is to take or to excise the largest lymph node as much as possible. Again, small or superficial lymph nodes usually give not specific result, and should be avoided. And while a deeper lymph node, the specimen should be received again fresh in the lab immediately after excision, and the portion to be embedded in the paraffin should not exceed 3 micrometer thickness. And again, a technique that complements the study of the tissue section that is too often neglected is examination, what is called touch preparation from the cut surface. So if we take a fresh sample of lymph node, we can make a what is called touch preparation. Fresh sample, we make cut section and touch into slide, and a rapid examination by Gimza or Wright solution. And this is very, very useful, to give what is called an idea about what we are going to do if we are proceeded for histopathological examination, or sometimes we have to shift into flow cytometry. And this is very an important point, in the triage of the diagnostic tool, to make the diagnosis. We say that needle biopsy should be only used in certain circumstances, example for diagnosis of metastatic carcinoma, but usually it is not preferable in making primary diagnosis for a lymphoma, and it could be used for selection a representative node for biopsy for diagnosis of recurrent lymphoma, for example, or sometimes for the staging of the lymphoma, or even for the monitoring of the treatment. But usually sometimes give what is called troublesome result or confusing result about primary diagnosis of lymphoma. And thank you very much.